Welcome to the Women's Health Podcast. I'm Anthony Lowe, the physio detective.
And I'm Marika Hart, a pelvic health and musculoskeletal physio. Together we interview leading authorities, we answer questions and share our thoughts to provide the general public with the best quality information that we can find on all aspects of women's health. Please remember that the materials and the content on this podcast are intended as general information only and are for entertainment purposes.
They're not intended to be a substitute for professional medical advice, diagnosis, or treatment. Now, sit back, grab your favourite beverage, or do your own thing, and enjoy the show. Hey everybody, welcome to the podcast. It's a pleasure to be here, and welcome. It's nice to see you again, Marika. How are things going?
Things are going well. It is just the perfect time of year in Perth at the moment, where it's just 30 degrees. It's sunny, but not too hot. And I was down the beach with the dog today, and it's just living my best life.
Love it.
How are you?
It's going okay. It's taken a cool turn, actually. I think somebody told me today that we had the coldest night last night in Sydney in March for, I don't know if it's all time or whatever, but yeah, it's taken a cool turn and it's lovely. I actually like the cool. And well, our guest is currently sitting in a mountaintop somewhere. So allow me to introduce you to Nina. Nina is a Norwegian women's health and pelvic floor physiotherapist working in a private clinic and doing a PhD at the University of Bergen on the effect of exercises on diastasis during pregnancy and the postpartum period. Her long clinical experience affects her approach to research and dissemination of the results. She also holds a degree in health management and further education in sexual health and education, teaches women's health on the Bachelor Physiotherapy program, holds courses and talks, and tries to influence politicians to prioritize and improve women's health. Welcome to the podcast, Nina.
Thank you.
When I listen to that, Nina, I think, do you have time to sleep?
Oh, yeah. I do.
Beautiful.
You have to sleep. Sleep is probably the most important thing. And if you get enough sleep, then it's like you can do lots of things.
Fantastic.
Absolutely. And we love the fact that you do clinical work and you're using that your experiences and your ideas that come from seeing, patients and clients and looking into the research as well. And I'm like doing a PhD. Like my wife literally told me that she'll probably divorce me if I decided to do a PhD. So it's like, well, I guess that's off the table then. So I think
my husband would have said this. I think my husband would have said the same thing if he knew what was ahead.
Yeah. I would still love to do research. I'm happy to collaborate with anybody who wants to, take me along for the ride. I don't know what I can add, but always love this topic. So perhaps we can just so first of all, congratulations, you had a paper published recently, and that's very exciting to hear. But let's just start really basically, and do you have a quick definition of what diastasis is to you?
It's part of the female body, and it's a normal. When we talk about the pregnancy-related diastasis, I think it's normal for most women, and it's a completely necessary part of the pregnancy to allow space for the fetus. And for most women, this goes back sort of naturally during the postpartum period, but for some people, the diastasis, well, the interictus distance increases and it stays that way, and it might cause some problems. But when I'm doing both the clinical work and the research at the same time, I actually see that I think diastasis have been blamed for lots of conditions and problems and struggles that these women experience that most probably doesn't actually, well, it's not caused by the diastasis, but it's probably caused by other things. very often because they've got weak muscles, because they've been following the general advice that is out there not to do abdominal exercise. So I think it's time to change, and it's time to sort of normalize the whole idea of a diastasis. And I also think that we've been talking about like the 2-finger width. That's a diastasis. I think we need to increase that because it's normal to it's normal that the interactive distance increases when you've been through pregnancies and have had children. So that's my approach now.
No, preach it, sister. I think we can both get on board with that. It's interesting, like looking back, I think over the last, 20 odd years, I feel like when I first became a physio, I'd never heard of diastasis recti. It was just not a thing that was heard of. And I'm pretty sure my mum, wasn't constantly worrying about this separation in the abdominal wall after, 4 kids. I wonder where it was that things kind of went from, oh, this is a normal thing, and it's definitely a problem for some people, but for the vast majority of people, it's a normal natural thing and they function really well. I don't expect you to know the answer to this, but I'm just curious where we kind of went from that to, oh my gosh, we need to assess every single person, and if it's more than 2 or 3 fingers, then we need to really get hardcore on rehabilitation. Because Anthony and I have both seen, and I'm sure you've seen this as well, Nina, is women coming in. Like I've had women in tears come in postnatally with a 1-finger gap and say, my muscles have not gone back together again.
Yeah. Well, I think I did my bachelor degree in the UK at in Manchester, and I had 2 women's health placements for some reason. I don't know why. I never had the orthopedic and I never had the pediatric, but I had 2 women's health placements. So that's how I came into the field of women's health and physiotherapy. And at the outpatient clinic that I was working at, they actually screened all the postpartum women coming in for diastasis, even though they didn't present that as a problem. So if they came in and they had urinary incontinence or pelvic pain or low back pain, it was they basically screened everyone. So that's how I got into the diastasis field. And if they had a diastasis, then it was this regime that you couldn't do that, you shouldn't do that, you shouldn't do that, you should be careful with doing the abdominal exercises, and you should only be doing the transversus abdominis, careful sort of pulling inwards and do the pelvic floor exercises. And at that time I thought that was brilliant. And then I went back to Bergen, to Norway, and we started together with a colleague, we started exercise groups for pregnant women. And the first exercise group, we were 2 physios, and there were 2 pregnant ladies, and we were like, "Wow, this is brilliant." So exercise for pregnant women weren't that sort of a big deal. And I took my knowledge from the UK back to Norway, and I started screening all these pregnant women and all the postpartum women for diastasis, and told them that they shouldn't be doing that, they shouldn't be doing that. So I've been there and I've done that. But then when you sort of get some clinical experience, and I had at that time quite a few colleagues doing sports physiotherapy, and when they were doing the exercises and they were reasoning why they should do those exercises, and when you were looking at the anatomy and how the muscles work and the abdominals work together, things just didn't add up. And then I started to try to get these women into doing more abdominal exercise, but I was constantly sort of, oh my God, I'm doing the wrong thing because I've been taught not to do that. but it sort of felt natural, and it was yeah, and making these women feel strong, and making these women coming in and as you said, they were scared because they had this bulging, and they had this gap between the muscles. They thought they couldn't do they couldn't lift their children, and they basically stopped doing exercise and stopped moving. So getting them moving again, that became my main aim, and I just sort of stopped focusing on the diastasis. And then I spoke to Kari Bø, which is you know who Kari Bø is, and we were discussing this diastasis thing, and then she was a supervisor for Patricia Motta in Portugal, where they did the ultrasound studies on measurements, and where they actually found that when these women were doing the curl ups, the interrectus distance decreased, and when they were doing the transversus contractions, it actually increased, and that was the opposite of what we were doing clinically. And then because I think it was about that time, that's probably about 2014, there was a change, like pregnant women started coming to me and asking, what exercises can I do to my diastasis, and what should I not do? And I actually couldn't.
How do I prevent it happening? How do I prevent getting this thing?
And can I do it? Will I cause it getting worse if I do this and this? And I didn't have any answers. So then I actually started this master's degree just to get some answers. But you know, when you start researching, you don't get any answers. You basically just get more questions. So I did a study that was published in Physiotherapy, and that was what actually happens to the interrectus distance, or the linear, but when postpartum women do the pelvic floor exercise and the transversus abdominal contraction, and it increased the distance. And then I have always been sort of trying to get these pregnant women exercising. So, and as there were absolutely no studies whatsoever on pregnancy and the diastasis of good quality, I asked Kari if she would supervise me again, because she was one of my supervisors from on the master's degree, and she said yes. And we tried to get the funding for 3 years, and then in 2020 we got it, and that's when I started doing the PhD. So I actually got into the research to get some questions, or to be able to answer these questions that I got in the clinical setting. So I think the change sort of came about 2014, and then that's also when the social media started to sort of, well, the different platforms with Facebook and Instagram and all that, especially in Norway. And after that, it's just sort of, yeah, rocketed off. And what I think is what has been presented has been sort of like, it's all fear induced, like you shouldn't do that, and you shouldn't do that, and you shouldn't do that. And basically, I think that when professionals like physiotherapists and personal trainers, and when they say no, don't do it, that's probably because they don't know enough about it. So it's easier to say, to give these women advice not to do it, just to be safe. And I think that actually causes, well, can actually make these women turn into patients, because they get weak muscles and they get pain and they don't function in daily life with kids and everything. So I think we need to change our attitudes. But I can actually see that this change is coming. It's ongoing. And when my last paper came out 2 weeks ago, I'm just like overwhelmed of how many, well, the feedback that finally this paper came out, and finally we can say that this is not dangerous, and finally, and so that was really rewarding to get the feedback. Yeah, because it's hard work and it's slow. There's no quick fixes with the research. We need it to take time. And also, when I did this paper, it was during the COVID. I started my PhD probably about 2 weeks before the lockdown in Norway. So then physios we weren't allowed to work at all. So I wasn't able to recruit the women. And when we got to recruit the women, if they got corona, they had to be isolated, and then I was assessing them in certain weeks of the pregnancy. So if they were in isolation at that time, I lost them, so I had to start again. So it's been a pretty hard work, but very rewarding as well.
Yeah, absolutely hard work. It's and it is great, you know, it's great to be able to share what happens. Like, for instance, late last year there was your paper which showed the instantaneous changes at what was it, 27 and 37 weeks, right? And then
Yeah.
this longer paper just recently, we're currently in the second half of March 2024 for those who are listening in the future. So it's great to be able to say that, because like you said, clinically things just look different to what people are saying on social media. And you know, you were saying we think that it's other things. I think one of the reasons why people might be having symptoms, like you said, you know, there's the weakness, there's not doing much, but I think even the reaction to the diagnosis of diastasis, and then, you know, holding themselves in certain ways because they're told to, like, it makes people stiff and sore and compressed. And I think that contributes to their symptoms too, just because they don't like how they look, or, you know, how they feel. With respect to the cutoffs, you know, you've seen in the research about the different cutoff values. What do you think about the normative values? What would you consider to be normal? What have you seen as part of your research, and what do you think is out there as reasonable?
Well, it's I think here is the difficult sort of the two different worlds of the clinical world and the research world. When I did the master's paper and also the PhD papers, we wanted to use cutoff values that had been used previously, so that we were able to compare our studies with other studies. That's how we got the cutoff points, and also we didn't want the distance to be too small, because if it's too small, it's hard to get the good results. So basically, we really wanted the big ones, but there are not many big ones out there. It's like now I've been assessing probably about 400 pregnant women just during this PhD period, and lots of women come and believe that they have a diastasis, but they don't. And with regards to the pregnancy cutoff, we land on 2.8 centimeters, and that was for so we had that for both papers, again, to be able to compare, and so that there should be some similarities. If I were to do these studies again, I would probably increase that. I would probably say 3.5 centimeters at gestation week 24, because what I've seen is that most of these women around gestation week 24 is about 2 centimeters. So I think that's normal. When you've had when you, as soon as you've been through a pregnancy and delivered babies, I think it should increase. That the normal distance should probably be 3.5 centimeters. But then again, we're talking millimeters, and if we say 2.8 or 3.5, what does that really mean in the clinical setting? I don't think it mean anything, basically, because what we want to do in the clinical setting, we want good function, yeah. And I think that you can get good function with a lady who's got diastasis of 5 centimeters, and you can have poor function in a lady with 2.8 centimeters. Yeah. So I don't think that the cutoff values on the millimeters is really that important in the clinical setting, but it's very important in the research setting, so that we actually sort of get the more large diastasis that we can get into the studies, the better the results are, the clearer the results will be. Yeah.
Yeah. I think that's really, it's really interesting, isn't it? That because measured on active, measured at passive as well, that's different. And I don't think the IRD, the interrectus distance, really correlates with the protrusion, like the appearance of doming, coning, tenting, whatever people want to call it. You know, and like, for instance, just today I saw somebody who there is basically 10 months between her first baby and her second baby. And I assessed her today. She's 4 weeks today, postpartum. She wanted her neck and her back and her spine manipulated, actually. And she was not concerned at all about her diastasis. But I did my standard postpartum check, and she's got nothing. And she had 2 pregnancies within a year. Like, it's very, very interesting how all that goes, huh?
And I've like this is not something that we've seen or the results from our research, but when, as a clinician doing the research, I learn from all the individual that come into my room and lie down on that bench, and we do the measurements, and I ask them about how do you sort of how does this feel? Does it make it like movement difficult, or so I learn a lot from these women, and I think also because this has been going on for so long, I've had the same woman coming in and participating in the studies with 2 pregnancies. So they were part of the first study, and then they come back and they become part of the third study that I'm finishing up now. And in all studies, we measure these distances at gestation week 37. And for all these women that have been through 2 studies, the distance seems to be quite similar at gestation week 37 for both pregnancies, which I find really interesting, because I think, does that mean that the body sort of increases the interrectus distance to a certain point, and then it goes back, and then it remembers with the next pregnancy, and that's as far as it goes? Of course, if they have like a twin pregnancy or depending on how the fetus is positioned, then the interictus discum will probably increase more. But with these singular pregnancies, these women, they have ended up on the same sort of measurements both times, and I find that quite interesting, because we tend to hear that it gets bigger and bigger for each pregnancy, and the more weight you put on and all that. It's I don't think that's completely correct. And what we've seen from the RCT data as well is that risk factors that we have been thinking, like hypermobility and number of pregnancies will increase the diastasis more. But what we see is that it's probably the what happens to the belly itself during pregnancy. So it's like the abdominal what do you call it? The
circumference.
Yeah, and the symphysis fundus measurement. When we do that when we did those at week gestation 24, we could actually sort of, if you look at that, when you measure the distance at gestation week 24, and then you measure the abdominal circumference. That's a hard word.
It is a weird word, isn't it?
It's a weird word. And the symphysis fundus measurement, we can actually almost predict how large or small this interictus distance is 6 weeks postpartum, which is very interesting now that we are coming out with the third paper where we're actually looking at the risk factors. So, but that was like a taste of what's coming. So, what I think, lots of the factors that we think or that we believe will increase the diastasis probably doesn't do it. So, which is quite interesting.
I will say clinically, I've seen the same thing in terms of repeat pregnancies. I'll find that they tend to, their belly will pop a bit earlier because they've still got that residual bit of linear alba, softening. So they'll tend to pop out a bit earlier, but at the end, their interecti distance is more or less the same. It's interesting what you're just saying about the sort of fundal height and the circumference, and because you find those women who are very petite and they have not much space between their rib cage and their pelvis, and they just got to go out because they just don't have. There's nowhere to go, and you see those really tall ladies who just have so much space in there for their, baby and placenta and amniotic fluid and all the rest. But you see those petite ladies, and they, sometimes they can just stretch so much out the front. But good. I'm glad you're looking at other factors.
Yeah. But I think probably if we want to find the real fact that, like, what's really causing it, I think we need to dive into the genes and the what do you call it, the quality of the muscles and skin and because
there is
that's
that study where they looked at collagen type 1 versus 3 ratio, didn't they? And there's definitely a difference at a cellular level between those with significant rad versus not, which is cool. I want to make sure you have enough time to talk about the RCT, because I think it's the first one that I've seen of its kind. So
it is the first one.
Yeah. There you go. So I got a bit excited reading it. I'm like, woohoo! Okay, so somebody has looked at an exercise program of abdominal strengthening during pregnancy to say, hey, is it going to make it worse? Is it going to make it better? Is it the same? Why don't you tell us about how many people you had in this and what the program looked like and what your results were? I think that's really important.
Well, basically, as Caliber is one of my supervisors, she wanted this PhD to include an RCT. And my other supervisors thought that this was probably a bit premature because there were no studies, like basic studies where what actually happens to the interrectus distance when pregnant women do certain exercises. So we had to do that first, which is the first paper. And then we found there that the pelvic floor and the transversus abdominis muscle contractions increase the distance, and the curl ups and the head lift and the diagonals it decreased the distance. But if you combine these movements, then nothing really happened to the interactive distance, which is what we probably want during pregnancy, because we don't want to increase it more than necessary, but we don't really want to decrease it too much either, because you have to have space for the fetus growing. So I was actually quite happy when we got those results. When I saw that the pelvic floor exercises actually increased the distance, I was a bit worried presenting these results, because I have met women in clinical settings with a small diastasis saying, I've read this paper and I'm not going to do pelvic floor exercises because I don't want this to increase. We can't risk that. So for me, it was very important to do the RCT, but with an exercise program which can be adapted into clinical settings straight away, and actually give the pregnant woman the necessary strengthening exercises that she needs to actually get through this pregnancy in best possible way. So we had to go we had some good discussions on what exercises to include or not, and I am very happy with the results, because this is mostly what I do clinically with these pregnant women. So then I could get to test this out, compared to like Sandra's study, where she was doing only the rectus abdominis exercises. We now included all the try to sort of get all the muscles, the large muscles exercised, and also including the pelvic floor, because pregnant women should do pelvic floor exercises. And we did this sample size calculation at the beginning, and we found out that we needed somewhere around 100 pregnant women. We got 96 in the end, because there is, and those that we lost because they gave birth before gestation week 37, and also it was a bit hard to get these women. Most of them wanted to join the exercise group, and were quite sort of sad if they weren't in that group. But some of the women thought it was a bit too much exercise, because it was during COVID, and coming to the physiotherapy clinic twice a week to do the group exercises. Then you had to do twice a week exercise at home as well. That is quite a lot of exercise, and lots of these women had children from before, so like small children, so there's not that much time, and you're tired, and again, it was during the COVID period, so I am so grateful. Like now, when I'm finishing up the data collection, because the RCT paper that came out now, that's looking at the results at gestation week 37, just after the intervention, and then again at 6 weeks postpartum. But we're also collecting data 6 months and 12 months postpartum, and that's where the delay came in with the COVID. So we are finishing off the data collection. Well, I am finishing off the data collection in June. So that will hope that paper will be starting writing that when I get back after summer holidays in August. And I think that's when the interesting results will come out. But when I'm doing the last measurements now with these women that I've been following since gestation week 24, and now they're 12 months postpartum, I am so grateful for them. They have been in to the clinic 5 times during that period, and it's probably the most stressful period, especially the measurements at gestation week 37, just close up to giving birth, and then 6 weeks afterwards, which is when you have to go to see the GP, and you have to go and see the midwife, and you have to go to get the vaccinations of the children and everything. So I am just so in awe of all these women that have actually, and the dropouts have been minimal as well. So, but I planned that because the physiotherapist that did, that had the exercise groups, that's one of my dear colleagues, Åsa Egge, and she is, she's such an experienced physiotherapist, and she's like, she's nice and she's kind, and everybody open up to her, and she is the perfect personality to keep people coming and making sure that they are seen and they are heard and everything. So I think I did a really good choice there, putting her in charge of the exercise groups. Yeah. So it's yeah.
It's exciting to hear. And look, we would love to hear about the 6 and the 12 months. For people who haven't read the paper yet, what was, I personally have questions about your exercise program. I know in the paper that you refer to the Norwegian recommendations, and I went to look them up online, but because I don't speak or read Norwegian, it was quite difficult for me. And so that was
basically
difficult.
the Norwegian guidelines are that pregnant women should do exercise as normal, which is the 30 minutes of
Moderate to high intensity.
yeah, it's basically the same. And also it says that you should do strengthening exercises for the pelvic floor, and you should do strengthening exercises for in general, but especially for the large muscle groups, back and legs, and also that you should avoid doing exercises including the rectus abdominis during pregnancy.
So you should or you shouldn't?
Shouldn't.
Right.
So the
Because that will then
Norwegian
answer.
guidelines, yeah, the Norwegian guidelines build on the Canadian guidelines, and the Canadian guidelines are sort of not the guidelines itself, but in the paper presenting the guidelines, they actually say that pregnant women shouldn't do these exercises because it might increase the interrectus distance. And
Because
yeah.
I'm looking at your exercise program and I'm like, there's not a lot of rectus work here directly, you know, like it's I know there's stuff in there. I know there's stuff in there that you get. But there's certainly not the classic, you know, there's certainly not the classic work that you get there.
Well, the first thing I like doing sit-ups during pregnancy is not a good idea, because you shouldn't be doing the supine exercises after pregnancy month. I think it's gestation week 16 in Norway. Basically due to the vena cava issues and those for those women that don't sort of get the immediate reaction of uncomfortable and that they are at risk of not getting too much or enough oxygen to the fetus. So that's, we stay away from that. And also I've always done all exercises for the pregnant women in standing up, basically because it's quite hard for these women to get up and down from the floor if they've got pelvic pain issues and stuff like that. And also they experience most of the pain when they are standing up. So I've had this thought since I started the pregnancy groups that we should do the exercises in standing or sitting. And I also think that the body is, I'm not really into strengthening one muscle at a time. I am more, I believe that we've got a certain amount of time for these women to do the exercises, and we need to do exercises that are functional and include the more muscles you get into one exercise, the better it is, I think. And then if it's also important with the quality of how you actually do the exercises, and that's where it also comes in. My colleague who was the physiotherapist, that she actually was correcting all these participants while they were doing the exercises to make them feel how it should feel, and all the exercises should feel pain-free, natural movement. You should be able to breathe while you were doing it. And also, I don't think, I don't believe that we should do, well, we probably should do a study where we were only looking at the effect of the rectus abdominis, but how functional is that? And do we have time for that? And do we have time to do that research for like 4 years? And then we do the research with the functional exercises, and we're never going to get there. So that's why I really wanted to include these exercises into this program. And it's correct, as you say, that there are not many. We've got the crunch in the sling, which is probably one of the exercises that sort of addresses the rectus abdominis especially, but the other more functional exercises in the program includes the rectus abdominis muscles, as it also includes the diagonals and the transversus abdominis, which I think that's just my dog. I think that's actually one of the strengths of this study, the exercises. I believe that, because
it's certainly different, like it's not the common program.
No, and it's how we can actually more easily implement the research into the clinical setting.
Yeah, it's a nice program. I wasn't criticizing the exercises, but the Norwegian guidelines saying you shouldn't do rectus specific type exercises during pregnancy also helps me to see, okay, well, that's why they probably didn't do this, the crunches and the other things. The results, I'm happy to hear the results. One question I had about the results, because the results were that basically not much difference, right? So was there enough load to make a difference, was my first question. Like, did they work hard enough to make a difference one way or the other? But can you explain what you found from this RCT, please?
Yes, it is, as you say, the aim of the RCT was to find out if there is any difference in a group of women doing these exercises compared to a group of pregnant women, who didn't do those exercises, but were actually free to do whatever exercise they wanted to do. It would, for the study itself, it would probably be better if we had the control group not doing anything. If we could have told them to lie down on the couch for 12 weeks, that would be brilliant, because then I think it would be it will probably be a bigger difference. But
yeah, but you've probably got some ethical issues with that, though, right?
definitely. And also, I could not be. I wouldn't be able to do a study like that, basically, because I know that if those 48 women lying on the couch for 12 weeks, they would definitely need physiotherapy afterwards. So they were actually recommended to follow the general exercise guidelines, and it turns out that the control group did quite a lot of exercise, which I think is good, but it's probably because they entered this study wanting to do exercise.
Could it be that they're also Norwegian and just naturally, maybe on average, more active?
I would love to think that, but I don't actually do think that it's correct, because in Norway we have 30% of all pregnant women are either overweight or obese, and 15%. There's a study from 2013 showing that 15%, well, less than 15% of Norwegian women, pregnant women, do actually follow the guidelines.
Hey, that's the same here. Ours is 15%.
So we have a pregnant population that is overweight and inactive. So I don't think that the control group in this study is actually representative of the general Norwegian pregnant woman. No, I don't think so. But for the study itself, well, we found that there were no differences in the interactus distance clinically, well, statistically significant. But when you look at the results and the numbers, it appears that there might be sort of a slight, maybe 1-2 millimeters increase more in the interactus distance in the exercise group compared to the control group. But again, that reverses 6 weeks after postpartum. Again,
and it's 1 or 2 millimeters. Like breathing will get you more than 1 or 2 millimeters difference.
Exactly, and the measurement error is so it's not significant, but it's there, and also it's reversed 6 weeks postpartum, where I think there, which is quite interesting, because we are doing the follow-up 6 months and 12 months afterwards, and there is a reason for that, because I think, well, I'm not quite sure what I think, but looking at the numbers, it might seem that the pregnant women that did the exercises during pregnancy might have a smaller diastasis postpartum. But we will have to wait to see the results from those data when that comes. But that's quite interesting. But basically, there are no difference. And I've got people coming asking me, but aren't you a bit disappointed doing this study, and there are no differences between the groups? But no, I'm not really that disappointed, because I haven't got the perfect exercise to decrease the interactus distance. I don't think that exercise
Nobody does.
exists. And that the exercise program that we landed on doing in this paper, in this exercise group, that's, as I said, exercises that we use every day in our clinic, and what we do with the pregnant ladies that come in with the pelvic pain and back pain so I think the most important result of this study is that it's not dangerous to do either these exercises or the other exercises that the control group were doing. Lots of them were doing ab exercises as well. That's what they've reported. And I think this study is more saying it's not dangerous to do the abdominal exercises during pregnancy. And I think that's probably the best result I could have got, basically. So no, I'm not disappointed that there's no difference in the groups. I'm actually quite excited because that it actually means that you can do whatever you want. If you want to do the CrossFit, if you want to do the yoga, if you want to do but if you want to do the strengthening exercise, then you should do you should do them at the certain load, as you were saying. But basically, you can do what you want. And that's where I want us to go with these pregnant women. Get the fear out of them and get them moving. That's basically
Love it.
what this paper is about, I think.
I love it, and I agree. I was just teaching in the USA, and I was able to say, "Hey, this paper just came out. Isn't it great?" Like, and I had the other paper to do with the instantaneous changes, because it's never made sense to me that transversus can bring an IRD together. It just doesn't make sense to me. The rectus is the only muscle that can possibly make that distance narrower.
Yeah.
But I'm interested, because you've scanned so many people. Have you ever compared their supine scan with how they scan in sitting or standing? Because to me, that would be really interesting.
Yeah.
Did you collect that data?
No, I haven't done that in the research. Then I've only been doing the measurements lying down. But clinically, when I get these women in with their diastasis and they want them assessed and they've got their problems, I do assess them supine in rest, and most of them come in with a fear of movement because they have heard that it will probably increase the distance, and some of them come in after pregnancy, and they are sort of blaming themselves that they've been doing lifting and the wrong stuff, and they think they've actually implied this increased interaxis distance on themselves. So what I actually do, I put them down on the plinth, and I show them with the ultrasound machine that look, this is what happens when you engage your abdominal muscles. They do work. They do exactly what they're supposed to do. They're brilliant. I measure the thickness just to say that you're doing really well. But if I get the larger ones with the mummy tummy, when they come in and they one of the main problems is that they feel that their stomach is bloating and it gets bigger during the day and all that. I do the ultrasound measurements in both lying down and in standing, because it usually increases quite a lot when they stand up. I think also that when you've got the really big ones, surgery is in some cases probably the correct thing to do. But in Bergen, the local hospital where where they do the diastasis surgery, they send them to physiotherapy now for 6 months of exercise to improve, not to close the gap, but to improve the function. Because when they come to get the surgery, or they want to assess if they can get the surgery, it's probably because they've got back pain or incontinence or uncomfortable, or they've got abdominal muscles that doesn't work, they can't engage their core and all that. And the surgeons there then send them to physio for 6 months exercises to do strengthening exercises of the abdominals especially, but also in general. And they also need to lose weight, lots of them. And most of these women, they end up not doing the surgery because they actually get a functional body. They don't have the back pain, they don't have the, and they actually learn to sort of live with their abdominal, how their abdomen looks. And one of my master students did an interview study on some of these women that were in my the first study, and actually asking them, how is it to live, what experience do you have living with diastasis? And that paper is coming out, hopefully not long before it comes out, but what these women want is information, and they want advice, quality knowledge, and good advice that is evidence-based. And yes, the abdomen is a very intimate part of the body, and lots of these women struggle. And I think that we really need to listen to what they say, and actually acknowledge that the it's not just the physical part of the diastasis, but it's also the mental and issues about self-esteem and how they live and how they're comfortable or uncomfortable with their own body. And I think that physios can do a lot there by making them comfortable in their own body, doing exercises, moving, getting them to actually feel that their body can actually sort of do what they want to do with their children and at work and as a partner and all that. So I think really need to acknowledge that aspect of the diastasis as well. And yes, hopefully that paper comes out soon, so we can get some quality data on that as well, because that is lacking out there.
Yeah, that's super interesting. And I was just thinking, Nina, in terms of, the exercise choices in your study, because it's, like you said, it's whole body, a lot of it's upright, functional. We've got squats and presses. We've got lots of obliquey twisting, kind of stuff. I'm always thinking, I guess, when it comes to pregnancy exercise, it's always that risk reward thing, right? Like I sat down with I was teaching with an undergrad this week, and it literally just sat down and went, these are the benefits of exercise. Like, we have so much research to show that exercise in pregnancy is really, really good. Yeah. Reducing gestational diabetes, preeclampsia, or blah, 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 blah. We can talk about it forever. Like, it's so important that, and then on the flip side of that, we actually had this interesting discussion, because she was told, you cannot, do not give sit-ups to postnatal patients with diastasis, which I was like, I'm going to respectfully agree with that. But there still is some of that messaging, and I do think it is evolving and changing, but I absolutely tip my hat to you and your team for doing big RCTs, huge amount of time and energy out of, I was actually asked if I wanted to do a PhD on diastasis about 7 or 8 years ago, and I said, hell no. And I was like, no way. So I'm so I so admire you for doing this, because it is huge. It's a huge amount of work. But I think what's come out of it, though, is, and I'm guessing from what you're saying, this is kind of what you're hoping for too, is that we can actually just say, look, guys, we have some evidence now to show that we can give people full body exercises that includes like some basic, upper abdominal work, some obliques, some, lifting overhead, doing all this stuff. And it does not mean that they're going to have a significant increase in interecti distance, either at the end of the pregnancy or later. So let's just calm the farm and maybe go more with the positive messaging of how important exercise and strengthening is. And let's get mums ready for mum life, which is bloody physical.
Yeah.
I mean, I've
it
got
is.
this 15-year-old, oh no, how old's my son? He's 13, I should say. My younger one, he's 13. He's bigger than me now, and he still runs and jumps on me. And I'm like, thank goodness I'm strong, you know, like I have to keep strong.
Yeah. And also, as a I did my degree in health management, and the role of physios in the in the whole health setting. I think that we need to acknowledge the fact that these women need to get moving. They need to exercise. And I also think that physios are probably the first choice, because we know what can go wrong, but we can also we've got the knowledge, and now we've actually got the research saying that it's not dangerous, and we need to sort of get the message across to these women, and also to employers and other health professionals, so that we can get these women moving. Basically, that's the most important thing for me, and it probably comes across during this talk that I am a clinician at heart, and then I'm doing the research so that I can keep doing what I love to do. But then I can sort of stand up and I can say, well, I can actually prove that this is not dangerous to do.
Love it. It has been very much a preaching to the choir exercise today, Nina. We like Marika and I both love positive, empowering messages. We love taking the fear out of things. You know, it's fantastic to hear about you, you know, doing this randomized controlled trial, 12 weeks of abdominal and pelvic floor muscle exercise programs during pregnancy. The amount of time and the amount of people that you've been following, and for just how long as well, because you've got, you know, the 6 and the 12 months that's to come. You know, recognizing the fact that activity and exercise is so important. You know, I have a saying that I like to keep saying. It's restricting activity in the hopes of saving a vagina or a diastasis is not holistic women's health. You know, it's so important to keep active, and you know, like you said, I'm not sure I could run a study where we put people on a couch for 3 months. I'm not sure that would be ethical at all. We have too much evidence against it. And so, you know, to hear that and to see the whole body exercises, and to see that it didn't actually make much of a difference at all. And when, you know, if people are interested, go have a look at the numbers. We're not talking massive amounts of diastasis. Obviously, we would love to see more and more, and heavier lifting and all the rest of it. But for the majority of people, staying active is not going to make things worse. We've seen hints of it in the past in the research, and this just adds more to it. You know, so many people have had their minds blown by your paper late last year, which, you know, like, Marika knows, I've been preaching this message for a long time. Like, this stuff makes it wider. Why do we want to, like, just be accurate. Don't tell people that it makes it smaller. And instantaneous change doesn't necessarily mean that it's going to make a diastasis smaller. It just means that it brings it together, right? Like, so anyway.
And we haven't even touched on the aspects of how to measure and the depth and the distance and all that. But I'm not really into that. I'm more into just make this thing normal and get these women moving and exercising. And I think there isn't one correct approach to do this, but we should not use fear doing it. So that's probably
Amen.
Yeah.
Well, it's for me, not, just because you raised it really quickly, you can fake the depth thing. All you have to do is generate a little bit of intra-abdominal pressure and you'll make that a little bit shallower, and you can fake it. I've shown people using my ultrasound that, look, this is what it looks like. And then they're like, oh, and just getting upright, like you just said. Like, I mean, I asked you a question about measuring upright versus supine because I was hoping for that answer, which is, well, when you get up, it's just a lot bigger in upright. Like, we're quibbling about little millimeter differences sometimes, and we're measuring people on their backs, and it's like, well, don't you know what happens when you get them up? Like, it gets bigger.
Yeah.
So it's quite interesting to just make sure it's the whole thing. And before we finish, was there any other things that you wanted to touch on? It's been a fascinating conversation, and I've got ideas coming out of my head all the time
Oh
about
yeah,
diastasis.
bring them on, because I'm going to continue doing research definitely on this topic and other women's health stuff as well. But I think what the next project is, we need to do studies on women, not the postpartum women, because there is a natural healing during the first year anyway. What we need to look at is the women that had children like 10 years ago and the big ones. And that's now what we need to do the studies on, because then we can sort of look away from the hormones, and we can sort of get the
More than
I think
10 years,
that's
though.
the next.
Well,
load
the
'em up,
difficulty,
Yeah,
with more than 10 years, though, is that we start heading into perimenopause
menopause.
territory. So it's like, oh, it's difficult.
Well, we just started this huge menopause project at the University of Bergen now. So we're looking into lots of aspects there. So hopefully that there will come some interesting studies from that group as well. And yeah, maybe I'll do something on that population as well. So we'll see.
Well,
you've
what
got
about a
postdoc studies
postmenopause?
coming everywhere.
Pardon?
Yeah.
Got postdoc studies coming everywhere.
Yeah.
No, it's exciting. It's exciting. I would love to do research. I would love to be a part of any research if anybody wants to have me as part of their team.
Definitely. Yeah.
I've got so many ideas. But thank you very much for your time, Nina. It's truly a pleasure. And I hope you enjoyed yourself. And for everybody who's listening, please find Nina online. I'm gonna have to spell out your
I've been
Instagram
thinking
handle.
about maybe I should just change the name to something English because it's easier to say. It's yeah.
I'll put it in the show notes.
Yeah.
It's all in the show notes. We're going to put references to her papers down there as well.
Yeah.
And leave us a comment, share it, and read the paper. It's open access. And
I also always say that if there's anyone there with any questions or comments, or if they want to discuss a case or whatever, please contact me, and I will definitely get in touch, because
we say that too.
That's how we learn.
Still don't. Yeah.
I get a lot of emails. Maybe they're scared of you, Anthony.
Oh, do you? Why are people scared of me? I don't think I'm scary at all. So funny. It's so funny, isn't it?
Don't be scared of him. He doesn't bite.
No, it's probably because you're an internal therapist, to be fair. So, there's that.
Maybe. All right. Well, thank you so much, Nina. We really appreciate your time.
So nice to meet you guys. Finally, as I said in the beginning, I was a bit starstruck, but you were really nice. So yeah, it's good.
Thank you.
Maybe you want to come to Norway and do your course in Norway. Let's arrange for that.
I would love to.
Yeah.
I would love to.
Yeah.
I am actually going to be in Europe. I was actually going to tell you, I'm going to be in Europe in 3 weeks' time. If you feel the need to travel south to Rotterdam,
I saw
love
that.
to see you there.
that's why I thought maybe we should get you like up to Norway as well.
Yeah, I'm happy to extend my trip. I'll talk to my wife, and but yeah, it's.
And I need to create a
it's
course so I can travel.
Well, just you can teach any course.
Yeah,
You've got lots of stuff you can teach.
Come along.
But yeah, come along.
Yeah. Okay.
So thanks very much, Nina, for being on the podcast. I loved having you on, and we hope to have you on again when your other papers are coming out. Thanks very much. Well, that's it for this episode. Be sure to hit like if you enjoyed the episode and leave any comments or questions below. We'd really like to hear from you.
If you haven't already hit subscribe, please do so now so that you can be kept notified when we release our next episode.
Otherwise, thank you for listening, and we look forward to having you back with us for another episode of the Women's Health Podcast.